Hey everyone, my name is Michelle Hong and welcome to my Level 1 Fieldwork presentation. My fieldwork was in a memory care senior living community with a team of caregivers, medical technicians, and an activities director. The residents in this community are split between two floors based on their level of function. So the third floor had higher functioning residents and the second floor had lower functioning residents. The Vibrant Life is a program in this community that allows residents to create their own schedule based on their interests, preferences, routines, and abilities. Some examples of these activities are optional outings and daily activities such as exercise, brain games, gardening, and bingo. For my case study, I'll call my client Sharon. So Sharon's a woman in her mid to late 60s currently living with Alzheimer's. And based on my interactions with her so far and the information that we've learned about Allen cognitive levels, I was able to conclude that Sharon is most likely between ACL 2.4 and 2.6, meaning she's in late stage dementia. Prior to developing Alzheimer's, Sharon was a scientist working to develop various vaccines, including one for Alzheimer's. Sharon's strengths include going on walks and listening to music while sitting outdoors, and although she's unable to feed herself with utensils, she's still able to use her hands. And due to the environment and policy of her residential setting, such as understaffing and the lack of ACL training of care staff, Sharon experiences excess disability and occupational deprivation. The first article I used for my literature review was by Cook et al., which discusses the debate between medical model and psychosocial model. The medical model focuses on treating an individual based on their illness, disease, or diagnostic model, whereas the psychosocial model focuses on treating an individual based on the relational, interpersonal, and social context of distress. Three ways of responding to the medical framework were conflict, which is openly dissenting, compromise, which is strategically stepping into the medical model, and collusion, which is inadvertently slipping into the medical model. A limitation to the author's findings were that there are only 19 participants in the study, so the themes and experiences might differ from other clinicians. And another limitation was that some of the team-related strategies for working in medicalized systems might not always work, depending on the values of the team and the overall institution. The second article I used was by Law et al., which discusses what client-centered practice is, and the three that I will focus on are autonomy, enablement, and respect for diversity. In autonomy, clients are the experts of their own occupational function, and their values are respected with the goal to maintain their dignity and integrity. In enablement, there is a shift from a deficit model to an enablement model, and this enables clients to achieve goals by individual skill and environmental modifications. In respect for diversity, it states to not impose one's own values on the client and to recognize differences in values based or between the therapist and the client, but still support a mediation approach. However, three limitations to providing client-centered care is a client's physical and cognitive abilities, a therapist's value and beliefs, and the institution's policies and procedures. My critical incident was when the caregiver asked me to use utensils to help feed Sharon her dinner. I saw her self-feeding with her hands during lunch, so I wanted to let her continue performing these remaining abilities rather than causing excess disability. So to make things easier, I cut things into bite-sized pieces as she continued to feed herself with her hands. She wanted to get up and leave after a few bites, but I was worried the caregiver would see and use force to sit her down and feed her, so I tried asking things like, "Would you like a massage?" because she loves massages, or "Would you like to eat some more?" to give her autonomy. She responded yes to both my questions, so I tried to guide her to her seat, but before I could, the caregiver saw and came over and forcefully grabbed her to attempt to put her in her seat. I tried openly dissenting by saying I could try to get her to her seat and eat another way, but the caregiver still forced her into her seat. Sharon ate about a third more of her plate and got up again to leave. This time, instead of trying to get her to sit down, I followed her around with her plate and tried putting a piece of food in her hand. And because she would eat it, I continued to do so until she started to not let me put food in her hand anymore. And I was able to get her to eat 95% of her plate. I experienced a gap in practice when I fell short in being client-centered and began colluding. My intention was to be client-centered with a focus on autonomy and enablement, but I ended up deviating from my approach and failed to practice autonomy and respect for diversity because I didn't give her the option to stop eating and because I tried to impose my own values onto her by making her eat because I learned that individuals with dementia tend to experience weight loss. So instead I began colluding because I felt doing what the caregiver wanted would be in Sharon's best interest, because at least if I kept placing food in her hands to get her to eat, even though she didn't want any more, it was still a less aggressive approach than the one the caregivers were using. Despite my small attempt to openly dissent when I tried to intervene when the caregiver was using unnecessary force on Sharon, I felt my attempt was greeted with ambivalence because I was just a volunteer and it didn't matter what I thought. Barriers that prevented me from providing client-centered care were my own values and beliefs, the inability for me to recognize my own ability to influence, and Sharon's own cognition because it's slowly declining and she will need more support with occupations and she might not be able to fully comprehend questions asked of her. And what I could have done differently would be to start a conversation with the caregivers, discuss my desire to practice being more client-centered and provide examples of what that would look like. Brainstorm with them other methods I could use to help Sharon stop or eat more aside from using force. And another thing I could have done differently would be recognizing the differences in my values compared to Sharon's and respect her choice to not want to eat anymore and stop trying to make her eat more. In conclusion, developing a practice and practicing a client-centered approach overall leads to improved occupational performance and satisfaction in the client. So for my future OT practice, I can adapt strategies for working in medicalized systems as mentioned in Cook et al.'s article. And while it may be from an OT perspective how other care staff can be more client-centered, it's important for me to take into consideration the barriers and pressures that are preventing them from being more client-centered, while also recognizing my own ability to influence by starting productive conversations and collaborating together to create a more client-centered approach to care. It's also important for me to not lose sight of the small positive changes in a client and stand up for my own philosophy in providing the best care possible to my clients. Thank you.